Hello and welcome to the University of Edinburgh's first ever Research Insights. Thank you so much for joining us. Our scientists are back at work in the labs, but until you can join us there too, this is our way to share the latest in our research with you. My name is Hazel Lambert, I'll be your host, and I'm joined this afternoon from each of our living rooms by Professor Linda Bauld, Professor Rowland and the super team of Jen and Nick who are off camera but making everything work. First, the techie stuff. We'd love to hear your questions, so the Q&A box is open. You can type your questions there. Try to keep them short, and if you see a question you'd really like to be asked, you can give it a thumbs up, and that will help me to pick the most popular ones. This event is being recorded, but your camera and mic are off, so don't worry if the doorbell rings. And at the end of the session, I'll point you to a slide where you can tell us what kind of science you are most interested in. And then for the last Research Insights in March, I'll do my best to find someone who can speak about that topic, the one that comes up the most. Now on to this afternoon's event, COVID-19 Behind the Numbers. Wherever you are in the world, whether you're at home, at school, at work, if you're isolating, shielding, sitting in your bedroom on your phone, we are all in this COVID-19 pandemic together. So we had to make that our first topic. We hear constantly in the news about numbers of cases, infection rates, deaths, and something called the R number. And you'll see that Rowland is wearing his R on his jumper. Want to give it a little tugger. Many of you may have been unwell yourselves or lost friends or family members. We are all living these numbers, and behind every one of them is a person. So today we're going to explore how those numbers are put together and what they mean. And we are very fortunate to have two incredible scientists to help us do that. I'd like to introduce you to Professor Linda Bauld and Professor Rowland. So Linda and Rowland will speak for about 10 minutes each, and then we'll have time for questions. Linda is a professor of public health. Her expertise is in human behaviour, and most of her work before the pandemic was on cancer and health behaviours, so smoking, drinking, and diet. But since COVID-19 crashed into our lives, Linda has been doing a lot of work around the impact of the virus on human behaviour. And in fact, her day started at 6:20 a.m. with a media interview on Good Morning Britain. She's one of the people who's been helping us all to understand the restrictions that have been put in place to help protect the population overall. So Linda, when you're ready, over to you.
Thank you very much, Hazel, and I'm really delighted to be here, and thanks to everybody for joining. So just to check, my slides are clear. I hope you can see them. Great. So I'm going to try and give an overview to start off with about why numbers are so important in this global crisis, and try and highlight one area where the numbers sometimes change and why it's important to be alert and to try and interrogate data. And that's what researchers do. It doesn't matter what discipline you come from. We're all trained to be critical, to look at numbers, but also evidence more broadly, and to ask, what does it actually mean? And to be aware when it changes. So that's the example that I'm going to use. So I'm going to talk to you briefly about which numbers matter, and then give you an example of when the numbers change. And I'm going to use the example of hospital cases in Scotland and also deaths in England. So primarily deaths in England is what I'm going to focus on. And as Hazel rightly said, this is mortality, in many cases preventable deaths, preventable mortality, and all of the statistics are not just numbers, they're people. But just to highlight that as something that's changed. And then I'll spend just a couple of minutes talking about useful sources that you might want to draw on. So in thinking about an infectious disease epidemic, pandemic in this case, all populations around the world are struggling to understand this, and scientists are as well. And we have data from multiple sources, and in fact, I would argue there's an overwhelming range of numbers that can help us better understand the pandemic and also the measures taken to address it. And I'm a behavioural scientist. I'm particularly interested in what we try and do to address it. Rowland will talk about the reproduction number, but we also have confirmed cases. So those are cases of COVID-19 confirmed by a test which shows whether somebody has the virus, SARS-CoV-2, admission to hospital and intensive care units, and also mortality and deaths. Importantly as well, from my perspective, we have a wealth of data on knowledge, attitudes and behaviour, on things like mobility, which is one measure of compliance with restrictions, how much are people moving around, accessing public transport and other types of travel, and how effective interventions are. And these tend to fall into two categories. The first one I'm particularly interested in, what we call non-pharmaceutical interventions, things like face coverings, physical distancing, and also pharmaceutical interventions, which of course we're now hearing so much more about, treatments and vaccines. So what happens when the numbers change, as they have a number of times during this pandemic? So at several stages in recent months, the definition or classification of some of the key numbers has not been modified, or indeed errors have been made, and I'll highlight one or two as an example. And one case in point is how deaths from COVID are defined. So the World Health Organization, intergovernmental organization, uses the following definition: a death due to COVID-19 is defined for surveillance purposes as a death resulting from a clinically compatible illness in a probable or confirmed COVID-19 case, unless there is a clear alternative cause of death that can't be related to the COVID disease, like trauma. There should be no period of complete recovery from COVID-19 between illness and death. Now that's a really useful definition, and it's used around the world, but it doesn't specify an international standard for the time interval from disease onset, so when somebody tests positive for the virus and has COVID-19, to somebody sadly passing away from COVID-19. So when did the numbers change in relation to mortality statistics on COVID-19 in England specifically? So from the start of the pandemic, Scotland only included in official statistics, those are the data that are on the Scottish Government website every day, and you hear the First Minister reading them out at her daily briefings, deaths from COVID where the person had died within 28 days of a positive test. But in contrast, earlier in the pandemic, England reported all deaths in people who had a positive test, regardless of time since that test was confirmed as positive. And that's through what we call PCR, polymerase chain reaction test, which looks for the genetic material of the virus. And as Public Health England explained, it was decided to adopt this measure in April in order to be sure not to underestimate the number of COVID-19 related deaths. But this practice changed in August 2020 following a review. So what did the review find? And this is me just highlighting an example of how it's so important when we make comparisons in particular to know what we're comparing. So Public Health England examined all over 40,000 deaths and confirmed cases of COVID-19 that were reported up to the 3rd of August 2020. What they found was that 88% of deaths occurred within 28 days of a positive test, and 96% occurred within 60 days or had COVID-19 on the death certificate. Of those who died 29 to 60 days after their positive test, COVID-19 was included on the death certificate for 64%, and 54% of the over 4,000 deaths excluded by a 28-day limit had COVID-19 on the death certificate. So overall, 91% of deaths reported by PHE in confirmed cases up to that date in August had COVID-19 on the death certificate. So what that means overall is that compared with Scotland, for example, official statistics in England had overcounted COVID-19 deaths because of these differences in definitions by around over 5,000 people compared to the measure used in Scotland and indeed in other developed nations. And this is important because when you look at different countries in the world, you look at how many deaths they've had, say, for example, per 100,000 population or per 1 million population. And you say, well, have countries dealt with the pandemic well or badly? Then you want to be able to compare things. And that makes it difficult if you're using different definitions, which is the case in this scenario between England and the developed nations. And because of this review of asking, well, are we using the right definition for official statistics? It resulted in all 4 UK nations agreeing that the main measure used would be the 28-day cutoff. So in official statistics, somebody who passed away sadly from COVID-19 needed to have had a positive test within the last month. But the records of deaths within 60 days, so that longer period of a positive test, would serve as a secondary measure and provide a fuller picture through time. And those data are still available. And that's important because some people unfortunately become unwell with COVID-19 and might spend quite a long time in hospital. They may be unwell for more than a month. So it's entirely plausible, and you can see from these statistics that there are deaths from COVID-19 that happen in people who tested positive longer than 28 days ago. But the vast bulk, as you can see here, occur within that 28-day period, and that is a useful way that we can compare the data. So just briefly, other recent numbers that have changed in the last couple of minutes I have, and how the number of people in hospital with COVID-19 is classified in Scotland. And again, there we saw that number change a few months ago because there were people in those numbers who were in hospital. Actually, they may have had a COVID-19 positive test, but they were then being treated for something else that resulted in them still needing to be in hospital, but COVID wasn't the cause. Another one is how the test positivity rate is reported in Scotland. Some of you will know that percentage. So for example, over the last couple of days, I think it's been between 6 and 8%. It used to look a lot higher than that, and that's because they were just counting the proportion of tests that were positive of people who were newly tested rather than all the tests, which is more common internationally. So it was corrected. Key measures are used in the performance of Test and Protect. So the contact tracing service in Scotland, they were also recently changed, and that was due to a coding error. So they've recently been revised, and it looks like the performance is perhaps not as good as we thought it was after they corrected that. So is this a problem? Is this a mistake when the numbers change? Well, it's not, because it happens all the time. And a bit like in areas of work I do, we change survey questions sometimes, so you can't look at trends over time. So the key thing is when the numbers change, the changes need to be transparent when governments and public agencies are doing this, and they need to be justified. And if they're transparent and justified, then we shouldn't necessarily be concerned. But they do complicate comparisons between and within nations. So when you look at how countries are doing in relation to COVID-19, recognize that how many cases is a feature of testing, and there are things we need to bear in mind. So just last slide here, useful sources to keep up to date. I'm sure these can be circulated. There's some wonderful material online. I do commend the ONS infection survey, which is a great snapshot now with data from Scotland that shows you how many cases we have, not just relying on testing. And I particularly like the COVID social study, which uses so many of the behavioural and social measures that help us understand how people are responding to the pandemic. So thank you very much. And finally, we've been running webinars on COVID-19. If you're interested in international comparisons, do go onto the Usher Institute website and have a look for our webinars. You just put Usher COVID webinars in your search engine. Thank you.
Thank you, Linda. Yeah, those webinars, they're really interesting. It's worth having a look. And actually, at the end of Linda's slide there, she put a link to the Science Media Centre. And that's a really good tip because anybody can look at that information. If there's a big science story in the news, if you go to their website, you can have a look at what are all the comments that other research scientists have made on this particular story. And it gives you a much greater richness and kind of context about the science that's happening, what people think it means. Great. Rowland, over to you. So Rowland is an expert in mathematical modelling, and what that means is that he finds ways to link behaviour and numbers to make it all make sense. And pre-COVID, he looked at how infectious diseases spread in farm animals, but as he'll explain to you, the beauty of maths is that it applies to people as much as to cows or sheep. So over to you, Rowland.
Absolutely. So to the numbers, a sheep, a cow, and a person are pretty much the same, although, of course, we know that they behave differently. So Linda gave you this really comprehensive view of how numbers are used to help us understand COVID-19. And I'm going to take a little bit of a different approach to looking at behind the numbers, which is to try to explain a little bit more about one particular number. And that's the R number, or the reproduction number that she already mentioned. Now, some of you, if you've been following the news at all, will have seen the R number reported over and over again, almost on a daily, certainly a weekly basis. And here's just an example on the BBC News website. I'm just going to give you an advance hint that this particular image is actually wrong. So you didn't get it quite right. And I'm going to tell you why in just a few slides down the road. So what is the R number? Well, fundamentally, okay, what we want to know when we're talking about the R number is if I was infected, assume I'm a typical, an average person, okay, in Scotland, if I was infected with COVID-19, how many people might I infect? Okay, so how many on average would one person infect? And I kind of think about, well, what goes into figuring that out? Well, I can think about, well, if I'm this person going about doing my daily business, I've obviously got to be in contact with somebody. Remember that it's 15 minutes in close contact or direct physical contact means that you could have a good chance of transmitting to somebody else. And I might be in contact here with 4 other people. And then I have to think, well, wait a second, what if some of those people are people who I can't infect? Now, again, you might have heard in the news, the really good news that we've got a number of vaccine candidates. And once those vaccines are in place and people have been given that vaccine, some of those individuals will be protected. And so some of those contacts won't matter. And the next thing I need to think about is that, well, those are contacts that could cause infection, but it won't happen every single time. And in this case, of those 3-minute remaining contacts that I have that you see in my slide over here, only one of them might actually cause a new infection. And the last thing I want to know is that how many days am I going to do this for? So once you get infected with COVID-19, you're only going to be able to infect people for a certain period of time before you can recover. And in this case, in this quite artificial case, because we know it lasts longer than this, if I can infect everybody for 3 days, I need to consider every single one of those days. And keep in mind, what I do every day might be slightly different. I don't do exactly the same thing. I may mean slightly different people, might do slightly different things, but what matters is the average number of people I might contact, the average number who are protected, and so on. Now, if you think about it, I can take all those numbers, the number of people I have in contact per day, the fraction of them who aren't already infected or are protected by a vaccine, the probability that I might result in a new infection, and the number of days over which I might do this. And if I take all those numbers together, I multiply them out, I get the R number. And in this case, the R number for this example I have here is 2.7. Now I'm going to go back slightly and say, remember I said at the beginning that the number they gave in that BBC website is wrong. And in fact, what they quoted was something called R0, or what mathematicians call R0. And R0 is a very particular version of the R number. It's called the basic reproduction number. And it's called that because it is the value of the R number when I am the only person who's infected. Okay? If I'm the only person who's infected, then that number, the number of people who might be already protected, because nobody knows there's a disease out there, there's no protective measures in place, this is going to be 1. And if that number is 1, then that value of R, the R0, is going to be the biggest it possibly can be. And what that means is that if nothing else changes, and remember Linda was telling you earlier about how things could change, but we assume if nothing else changes in this case, then if R0, this first value of R, is less than 1, then the value of R for the rest of the epidemic or the rest of the pandemic will also be less than 1. And that's important for this reason. So imagine I'm this first person on the left. Now I'm in contact with 3 individuals, and each of those 3 individuals is in contact with somebody else. Well, if I, in this case, infect 2 of them, and they infect 2 or some number that has an average of 2, then what happens is the disease keeps going. It keeps spreading and spreading and spreading throughout the entire population. And as you've seen from the projections, if you looked at these in the news stories, that number can get enormous. It can reach into thousands or hundreds of thousands of people. And tragically, as has already been mentioned, a lot of potential deaths. Deaths beyond what you would normally expect. On the other hand, if that value of R0 is less than 1, what that means is those chains of infection. I might, by chance, infect 1 other person. That person might, by chance, infect 2, but eventually, because the law of averages works, what will happen is the disease will eventually go away. And so a lot of the things we do can be expressed in terms of whether or not that R number is above or below 1. So why is that important? Well, if you think about it, all the different things that we do to try to control the disease can be expressed in terms of those things that I mentioned before. So remember, towards the end of the last school year, those of you who are in school, you would have been going to school at home, and a lot of the people around you, people would be working from home, as I am doing right now. Well, what that means is, of course, you have fewer contacts to a person per day. That'll reduce the first number, R goes down. Remember I said if people are vaccinated, it reduces the proportion of individuals, the fraction who I might possibly infect. And so if I increase that number of people who are vaccinated, then this number, the second number, also goes down and R is again reduced. If I adhere to hand washing on a regular basis, that might also have an effect. And indeed, if I'm wearing a mask, again the R number goes down. And what you can see here, hopefully, is as if I add these number of measures one by one, each one of them may not have the effect of getting rid of the disease completely, but every single one of those numbers contributes. So what I hope I've shown you is that through some fairly simple mathematical arguments, I can see how different control measures have an impact on what the value of R is. But of course the question is, that all sounds good in theory, is actually measuring R as easy as all that? Unfortunately, the answer is no. It's often the case that we don't know what any of those numbers are, especially at the beginning of the pandemic, way back in March, when we actually had very, very little information. And sometimes all we really know is where the case is occurring, where people test positive, and also where they're occurring. So what can I do with that? Well, this is where it gets a bit more complicated, and I won't go into any of the details, but what we can do is we can write down a bunch of equations, and here, these are the equations that we're using right now to predict the pandemic in Scotland. We can run simulation models, so computer simulations which express those equations and all the kinds of data which Linda mentioned before about where the cases are, hospitalization rates, death rates, all those things go into a computer simulation. And by running those simulations over and over again, I can make my computer models try to match what is actually happening in Scotland. And this is a result of one set of computer models which we ran to try to fit the epidemic as it occurred across all the different council areas in Scotland. And this is a simulation with over 6 million simulated individuals, everybody in Scotland, with all the information about commuting and mobility patterns and how people move about from home to work in it. And I can take that and I can use that to try to understand what the R value is, and I can project that over time as the different circumstances change in terms of how we move about, in terms of how much our contact rate changes. I can predict what the R number might be. And this note over here is just to say that I'm not going to pretend that these particular figures are from our simulations. We haven't done this very detailed level analysis over the entire course of the pandemic, but you certainly can do that using similar models to what we have. Now, does this thing, this R value, or in particular R naught, tell us everything we need to know? I mean, after all, it contains all this information we have about disease transmission and how the control measures matter. And if we know that R is below 1, as I said, that tells us the epidemic is going away. Well, unfortunately, it doesn't. And certainly what people like me do is we spend a lot of time looking at how the simple assumption that I mentioned before, that R naught is the maximum value that you could possibly have, can change. And there's all sorts of questions that underlie it. For example, what happens if the virus changes? What happens if somebody moves from a place to where a lot of people are infected to some place where nobody's infected? What happens if the disease spreads more frequently some places than in others? So, for example, the restrictions around places like restaurants and pubs are largely around things like we call super spreading events. And what happens, for example, if I change who I meet every day? If rather than meeting the same people, if I now go somewhere else and meet other people's? And in particular, and going back to Linda's comments about behavior, what happens if behavior changes? What happens if, for example, lockdown fatigue sets in and people start doing more activities that they possibly shouldn't do? Now, if there's one concept I want you to come away from this, one mathematical concept, it's the concept of nonlinearity. So what do I mean by that? Nonlinearity is a little bit like falling over the edge of a cliff. If I have an R value of below 1, then everything is kind of okay. All right, you might get some people infected, probably from being introduced elsewhere, but broadly speaking, most individuals would expect not to get infected. But as soon as that R number goes above 1, the disease starts spreading, and starts spreading in a big way, and it means that vulnerability increases. And the point I want to make here is that this process, reflects this thing of nonlinearity or multiplication. Now, we expect when we make small changes in what we do, that's going to result in small changes in circumstance, in outcomes. So we increase activity a little bit by changing one of these numbers, and that'll only result in a small number of new infections. But what I hope you can see from what I've been talking about If that number R goes from below 1 to above 1, we have something that is very much like the perfect storm. Okay? Changes come suddenly and unexpectedly, and mathematics is one of those things that help us to understand it. People tend to think of mathematics as a way of forecasting. These models are a way of figuring out what's going to happen in the future. But I think one of the more important things is it helps us understand how our assumptions work and how they interact with each other. And because they're transparent, it means that even if the models are wrong, then at least you understand why they're wrong. And I'm going to finish off with this quote from a famous statistician named George Box, who said, "All models are wrong, but some of them are useful." And the idea here is that we're trying to develop useful models for helping us to understand COVID-19.
Lovely. Thank you so much, Rowland. And I just love hearing you explain that because suddenly I understand it. It's great. I'd like to invite Linda to come back on screen now as well. And the three of us can have a bit of a discussion. I can see some questions coming in, so don't be shy, guests. Please write your questions in the Q&A box. This is your chance to ask Linda or Rowland a question directly. So type it in there. Rowland, can we just pick up on one thing that you said towards the end of your presentation there? You mentioned this small world scenario of people moving from one place to another. And I know that we're joined by a group today from the Anderson High School in the Shetland Islands, where they're at level 1, but their student friends in Edinburgh, Glasgow, they're in level 4, level 3, and they'll be wanting to go home for Christmas. How does that fit? How does the small world theory apply there?
So the small world idea comes from an experiment that a sociologist ran in the 1960s. Now, it turns out the experiment itself was probably flawed, but the result was actually quite relevant. And what he did was he got people to try to send letters across the United States. And what he found was that it didn't take many jumps to get two people who had no idea who each other was to be in contact with each other. And the idea of the small world is also known as the 6 degrees of separation idea, which is that any one person in the world is no more than 6 jumps away from any other person in the world. And to go to your example of, say, students who are in the Shetlands as opposed to being in Edinburgh, most of your friends are probably going to be people who live pretty close to you. Yeah? But every once in a while, there'll be somebody who knows somebody quite well who lives quite far away. And what's important is that because you have those interactions, it means that even though you seem that something like a disease risk is actually quite far in Edinburgh as opposed to the Shetlands, all it takes is one of those individuals to introduce the disease into your population. And that makes that, really distant thing suddenly become small. And so the term small world comes from that phrase when people meet each other, they realize they know somebody in common and say, isn't it a small world? How did that happen? And the reality is the mathematics tells us it happens more often than you think.
Great, thank you. And Linda, for you, we've got a question from Laura, and she says, what kind of long-lasting effects will COVID have on our understanding of human behaviour during pandemics? So that's really thinking ahead.
It's a really good question, Laura, and actually it's something that behavioral scientists are giving a lot of thought to, because previous generations of psychologists and people who look at behavior more broadly, and neuroscientists as well, have looked at when we've had a crisis, how have people's behavior changed over the longer period. And you actually can see in some populations that there is a footprint in terms of their interactions, which is born out of crisis. So that does happen. And some of our cultural norms are shaped sometimes by crisis. However, in relation to, if you think about the big behavior changes we've had to adjust to in the UK, things that we're not used to doing, wearing face coverings, keeping ourselves apart from others, not physically, shaking somebody's hand or giving your relative a hug. I think those are relatively time-limited behaviors that we will abandon when we observe others around us, because we're social creatures returning to the norm. So if we're not wearing face coverings anymore, the government doesn't necessarily require it, and we gradually see people not doing it, but perhaps an older or more vulnerable person when in the supermarket will wish to continue doing that, right through next winter and in future winters, for example. And then with the shaking hands or giving somebody a hug, again, when we see others around us doing that, and official advice, showing that it's not a risky behavior, we will revert to the norm. And the things I'm more concerned about, and I think might take us a bit of time to adjust to, and I'll try and be briefer, sorry, Hazel, is a lot of us have been very isolated for a long time. We've really reduced our social interactions, and I think some groups are more resilient, young people, but there'll be others of us who I think our approach to social interactions might remain more cautious for some time to come, or more selective, which is not a bad thing when it comes to, for example, meetings that don't need to be in person and could be virtual. So that's a long answer to an excellent question, but I hope that's helpful.
Yeah, I think that's something we're all talking about in the workplace as well, isn't it? What will we take back into the workplace that we've started to do now? And it is so convenient just being able to call someone from the screen in your living room rather than having to drive across town for a meeting, for example.
Yeah, and cheaper and better for the environment as well.
Yes, yes, that's true. All right, another one for Rowland.
Mm-hmm.
So this is from Ask. I think that's probably somebody's initials. What size of area does the data deal with? You talk about local authority areas, and the data tell us about community level.
Yeah, so you've probably heard of the term big data, and big data represents getting more and more information about a lot of different things, but in this case, more information about populations of people. So what we have is from the Statistics, Office of National Statistics, is information about commuting patterns, so the way people move back and forth to work. And that data is resolved, so we know that information down to a very, very small area. So we use the council areas as a way of gathering up that information, but underneath it is essentially a computational engine, a computer program, which actually looks at how people mix in units of about 50 to 100 people. Okay. Now, all that detail inside it isn't necessary, but there's a lot of things that change if you change the size of those units. I know that's a slightly complicated answer, but I suppose the simple one is we can use a lot of information from the statistics, also from things like Google. So what Google do is they give us information about how the amount of mobility, people moving about, changes from day to day. And indeed, they tell us because your phone, if you have location settings on, tells you about how people move about. And we can use that information to sort of moderate the amount of transmission and the amount of movement going on. So there's a lot of detail out there.
That kind of detail is incredible as well, isn't it? It's like when I get in the car in the morning and I plug in my phone and it immediately tells me it's 7 minutes to the location that I go to every morning. I never asked it to do that.
Yeah. Yeah, and your phones know a lot about what you're doing, so it's something to be aware of.
For medical research, can't it? It can, it can show information about when people's illnesses are starting to get worse, that kind of thing. Anyway, we have a question from Strathallan Biology that is the most popular one. It says, we're likely to face the winter pressure this coming December. So this is all about the restrictions relaxing over Christmas. Does it mean that there's going to be a third wave after Christmas? What do you think?
Shall I start?
Go for it.
Okay, so I think actually that Strathallan Biology is actually asking two questions here. Winter pressure, around normal winter pressures, how I would interpret that term, which is pressure on the health service. I'll say something briefly about that. And then around the relaxation of restrictions. I know Rowland's been speaking about this today, so he'll contribute as well. So normally we face winter pressures. That's something a number of us have looked at in the past. And that's just because of the colder months, you have more respiratory illnesses. And then there's all kinds of things that can happen from people slipping on a patch of ice and all things that just happen that are associated with winter. So the NHS in Scotland now, I think, is operating at about anywhere between 80 and 88% capacity nationally. And that's about normal for this time of year. And it's going to get worse as we go into further in the winter. So when you add COVID cases onto those existing pressures, it's very difficult for the system to cope. And that's why we built extra capacity. The one little wild card in that, which I'll say is flu. Now we're vaccinating lots of people now. But if you look at my colleagues in the Southern Hemisphere, Australia, New Zealand, Uruguay, Argentina, etc., they've seen actually lower levels of influenza in their winter during the COVID crisis, because people are distancing, they're using hand and respiratory hygiene, things that actually prevent flu from being transmitted as well, or the viruses associated with flu. So we might not be overburdened by flu because of vaccination and that. So that's a good thing. But on relation to Christmas, just briefly, yes, this relaxation of restrictions will result in additional cases, unfortunately, of people contracting SARS-CoV-2, because when people come together, that's what happens. But there's a lot of things we can do to mitigate that. And I think that's why you've heard from our government, particularly in Scotland, that just because 3 households can mix and you can travel around the UK, it doesn't mean that everybody is required to do that. There's a level of personal autonomy. And I think we need to be very cautious, because Rowland and I both have Canadian connections, and we saw with Canadian Thanksgiving, even though that wasn't a major contributor to their rise in numbers, it looks like it had an effect. That was a holiday in mid-October. Mm-hmm. So we need to be cautious about Christmas. I think it will have an effect, but if we can moderate the advantage we take of those easing of restrictions, then it will have less of an effect.
Thank you. Rowland, do you want to add anything there?
Yeah, I mean, Linda gave a pretty comprehensive answer, so I'm just going to take this as an opportunity to talk a little bit about a pet subject of mine, which is about how behavior and models interact. So my view of it is that we're going to be increasing certain risks over Christmas time, just to address that second question. But the question is that increase in risk going to be more or less than what might have happened if we didn't have some easing off of restrictions, and instead people who are frustrated over restrictions might be doing things anyway? All right. Now, human behavior is a funny thing, and as we all know, that human behavior has a sort of cascade effect, that if you see other people doing a certain thing, we have a tendency to do the same things. And one of the ways we can look at that is something called game theory. And some of you may have heard of something called the prisoner's dilemma, for example, which if you haven't, you could Google it, or feel free to ask me afterwards if you want. But what it means is that communal behavior can sometimes result on its own accord from doing things which you never intended to in the first place. And it's sort of an argument to say that, when you do things, when you follow these restrictions or not, you have to remember that maybe the risk to you isn't that great, but a lot of it is how your behavior influences the behavior of others. And what game theory tells us is that sometimes, in the same way we have these nonlinear effects in the disease, you have these sudden shifts in behavior. I'm going to give you another example. This is one Linda will know quite well. You think of the number of people who used to smoke in the UK, right? And the number was enormous, and some of you are probably too young to remember this, but all of a sudden, largely because of changes in societal attitudes, the number dropped off the table. And that can go in the other way as well.
Okay, thank you. Now we've got yeah, that's okay. We've got 3 questions from Doug Flett. He was first out the door. So he is asking, given the difficulty in specifying cause of death in much older people and elderly people who are hospitalized, is the World Health Organization description fair or biased toward an overestimate? So that's about what we know about accuracy of numbers of older people dying from COVID in hospital.
Okay, well, I think he's got 3 questions, so I'm just going to answer this one briefly, because let's get on to Doug's other questions, because they're really good, and they're for Rowland. I mean, what I would say is it is erring on the side of being perhaps too inclusive a definition, but it's not unique to this disease. So this is quite a common classification that's used. So again, if you look at the wording, for surveillance purposes, and I emphasize this, as a death resulting from a clinically compatible illness in a probable confirmed COVID-19 case, unless there is a clear alternative cause of death. And so what you normally see on death certificates, and sorry I didn't go into all this detail, is you have a primary cause of death, but you also have other conditions that are listed that may be contributing factors. And that's what you'll see with the COVID-19 thing. I absolutely agree with Doug that with older people, it's sometimes, for example, dementia can be a cause of death, but clinically how you confirm that dementia caused the death is quite challenging. So, but I don't think that the WHO definition is at odds with how we would try and classify, for the purposes of registering a death, other conditions. I think what the challenge is in comparison is much more about how different countries have interpreted how they report their official statistics. Many of you might have heard of Belgium, for example, which looks like it's been doing really badly in its mortality rates, but they've used a very broad definition of COVID-19 mortality. I'll move on, let you move on to Doug's other questions, please.
So his other question was for Rowland, which was again about estimating numbers. And he said, so as not to underestimate, as opposed to why so as not to underestimate, as opposed to overestimate.
I'm going to confess, I don't quite understand the question. And Doug, if you want to try to maybe retype that, I see there is another question. I'll try to answer the second one, and then can we adjust our assumptions as a result of the consistent huge overestimates over the months? Now, I think the thing to keep in mind here is that the initial estimates are made. They often quote what are called the least worst case scenario, all right, as sort of an outer limit of what things might be. And you have to be careful about the difference between what's reported in the news and what might be considered the central estimates of what might happen. And I think that's an important point to make. Okay, what comes up in the news is not always necessarily the way the numbers are being judged internally. Even with that, there is often a tendency to assume a kind of a worst case scenario. However, to directly answer your last question that I see, there's always a refitting, a readjustment. So what we do is on a regular basis, we look at the data as it's updated and we update our projections on the basis of that. So absolutely you're right that long-term predictions can be highly variable, and they can often be quite different from reality, but they do get better and better as you get closer and closer to the times that we have.
Thank you. And then this is a great question from David Porteous. Thank you. He said, do you think that now that we know there's a vaccine on the way, it could lower our guard and change people's behaviour?
Yeah, I've been giving quite a bit of thought to this and trying to think what the evidence behind this is. So, as usual with human behavior, there's not yet necessarily a simple path that people would take to behaving in a certain way. So I would think this falls into two categories, David. The first one is that people may feel, well, it's all over and there's going to be a vaccine, so therefore I can relax and I can engage in more risky behaviors. I haven't seen much evidence of that. And again, I had a look at the literature and what might give us a precedent for that, but it is plausible because there is fatigue. There is definitely behavioral fatigue. And if you look at the UCL COVID social study, you can see evidence of that behavioral fatigue in terms of majority or complete compliance, which has definitely declined when we came out of lockdown in the summer and has never quite regained when restrictions were put back in place, because people are it's always easier to do short-term than long-term behavior change. That's evident in the literature. The other argument actually though is because there's a vaccine and we may be getting access to that in the coming months, people may actually decide, particularly those who are more risk averse, to continue to be very cautious because they know there's a route out. And I have seen some evidence of that and discussed it with colleagues. So conversely, it may actually give support and hope to people who know they need to comply for a bit longer because there's an exit strategy. And I think that's probably going to be more of the dominant behavioral response rather than the former.
I think we have time for one last question, and since we've been speaking about vaccination, we'll carry on in that theme. And we've got a question from Hector who says, how quickly do we have to vaccinate the population for it to be effective?
I'll give that to Rowland.
So there's two different approaches to vaccination. If you have enough vaccine, what you can do, and if the vaccine is good enough, what you can do is try to vaccinate as much of the population as you possibly can. And the result of that, if you remember the R number value that I gave you, if you can get that fraction of people who are protected high enough, the R number goes down below 1, and you can actually see the disease go away altogether. Now that process could take quite a long time because after all, there's 6 million people in Scotland. We've never done this before, and there's a lot of logistics that have to go into it. People have been thinking about this, but to produce the vaccine, to do that could take quite a while. And I don't know exactly how long, but it won't happen right away. On the other hand, vaccine has another incredibly valuable role, which is that it can be used to protect those people who are vulnerable, and it can be used to protect those people who are in positions of higher risk, like health workers. And if you use that right away, then that alone could do quite a bit towards allowing us to reduce the restrictions we have. But an important cautionary note to that is that while we know that the vaccines we have protect people from showing clinical signs, we still don't know if they protect people from infecting others. And in fact, it's precisely the people who have mild infection who are more likely to continue doing exactly the same things they did before infection. And if that were to happen, then those initial stages of vaccine could potentially, if people started thinking they didn't have to do anything else, again result in a way Linda was saying, in more cases rather than not. So again, fantastically good news that we have these vaccines potentially available really soon, but a sort of a cautionary approach has to come forward in terms of how we use them.
So the message for you all to share with your friends is, even once we start getting the vaccine, keep being cautious and keep following the public health rules. Rowland and Linda, thank you so much. I think with that, I'm going to bring the event to a close. Thank you for sharing your work with us. Thank you to all our guests for joining us and for your questions. I really hope you've enjoyed it. And thank you to Jen, and Nick for making it all work. Our next event is at the same time on Wednesday, the 9th of December, when Dr. Richard Weller is going to talk about heart disease, inflammation, and why he thinks a bit of sunshine is good for you. Now, I'm going to put up a slide just now with a code to menti.com. We'll leave it here for the next few minutes. And if you go to the website and put in the code, then you can tell us what topic you would like to see covered at the event in March. So I'm going to say goodbye now. So take care, stay cozy, and I hope you can enjoy and join us again in December.
Thanks, everyone.
Thanks,
Bye-bye.
Hazel. Thanks, everyone. Bye.